You I know, most of you in this room actually, I would say. Okay, um, okay. Revision arthroplasty. Where's this clicking? I'll just do this. Does this work? Well, there you go. Thanks for coming. Where are you going? Just these?
Yes.
Oh, okay. Let's do this. And this is where the online people are coming from?
Oh, yeah.
Hello as well to the people of the internet. Okay, I'll get us right into it. Okay, so roadmap for the talk. Talk about what is arthritis and what it is that I actually do. What's a primary hip or a knee replacement? What's a revision hip or a knee replacement? And then we'll go through some cases. And then, since, we get a small group here, if you have a question, just feel free to interrupt me, raise your hand. I don't know if the online people can ask a question, and then Quinn will do it. Our A-plus IT team here, and some more IT team here in the back. He's raising his good hand. Okay? And then also, as a reminder, don't forget to grab some stuff. These little hand sanitizers are a hot ticket item around here. I see that there's some special edition red 4th of July ones. And if for some reason you need more, this gentleman here, also wearing red for 4th of July, shout out Brian McTurnan, community outreach extraordinaire, he'll get you whatever you need. If you have any problem at all in life, find that guy, tell him I sent you, he'll solve it for you. Also, always got a shout out to the team. This is Megan, Kelly, and Katie, my PA, MA, and nurse, who are, I think, still in the office doing work while I'm here with you fine people. Okay, so what is arthritis? It really just means a painful joint. So there's a lot of different reasons for that. When people think of arthritis, commonly they're thinking of osteoarthritis, which is the wear and tear of life. So that would be a degenerative knee. You can get traumatic arthritis. Let's say you had a fracture where you broke the top of your tibia. Even if you heal it up, sometimes it doesn't heal perfectly, so that can lead to a traumatic arthritis. Septic arthritis if you get an infection, and inflammatory is things like rheumatoid and other, basically that type of disease. But the bottom line is it erodes the cartilage in your joint. So what does that look like? The cartilage is the shiny white stuff on the end of the bones, if you can think of like a chicken bone. And then it wears away, and you can kind of see some, in real life, it looks just red and inflamed, and you can kind of see the bone. On x-ray, you want to see the space here. Is this, oh, the pointer's not working on here. I'm showing it on mine, but I don't know if I have a pointer there. But the loss of joint space, when the bones get closer together, that's what arthritis is. So this is an example in the hip. On the right side, which they throw a big R on there so you know which one's the right, you can see that there isn't space. There are cysts. Geez, is there a way for me to get a pointer? Do you know? Yeah. Yeah? No. If not, it'll be fine. Hello.
No, not that.
Oh, is that a real laser pointer?
It won't show on the TV.
Okay. All right.
Laser right there.
This?
Yeah. Laser.
Does that work?
Yeah.
Oh, nice. Okay. So these are cysts in the bone. So this hip has some good space. You can see it there. And this one, there's no space. And then as you get cracks in the cartilage, joint fluid goes into the bone and it causes cysts. So that's what that is. So what is a hip or a knee replacement? A few different pieces of metal. This is kind of showing bad hip and with the replaced hip. So hip replacement is 4 pieces. There's the metal stem that goes into the femur, then a ceramic ball that goes on the edge of that, a plastic, and this socket that kind of goes into the pelvis. So when you put those all together, this is kind of what it looks like. This is kind of showing the 4 pieces. A knee replacement can be 3 pieces, sometimes 4, if you're going to put a plastic button on the backside of the kneecap. That's somewhat controversial. That's a whole talk for a different day. But you can kind of see it as the metal piece that goes on the femur, the metal piece that goes in the tibia, and then there's a plastic insert between them. Questions so far? Yeah? Good? Okay. And this is kind of what it looks like all together as an x-ray. The plastic doesn't show up on x-ray, so you can kind of see it right here in between. So a revision. A revision is redoing it. And this is what I did my fellowship training in. So you finish your residency, and then you can be done and go practice orthopedic surgery. But a lot of times today, people will do an additional year of bonus training in something specific. So I spend my year doing extra training in redos. Why would you need to redo it? If it gets infected, if the metal loosens from the bone, if you have instability, if there's a mechanical failure of the components or the bone, or if somebody falls and fractures, which is, I guess, a form of mechanical failure. But something worth noting is that a painful hip or knee replacement is not necessarily a reason to redo it. So you always got to rule these things out. Somebody comes to me in the office, these are always the things I'm thinking of, and some of them you can check on x-ray, some of them you can check on an exam. You kind of put it all together. What is this? I don't know if it got cut off. But anyway, this says challenges of revision surgery, so things that make it difficult, because somebody's already been in there before. One thing is you got to get the exposure. So typically, the surgical scar is a little bigger than the first time because you need to be able to see everything to be able to fix it. You're going through scar tissue. If you have to take the old components out, that is sometimes easier said than done. When you take the old components out, now you have to deal with the bone loss from what was in there. People can have damage to their ligaments, which can affect the stability of the hip or the knee. And then you need to create that stability. And if there's an infection, then your first step is always figuring out a way to eradicate that. So infection. This you can diagnose with labs. The best way is to take fluid out of the joint and send that to the lab. If somebody has a draining wound, then the outside world is communicating to the metal. So that alone is a criteria to call something an infection. And sometimes you can see x-ray changes. So this is the same hip several years apart. And when you see these kind of scalloped edges around, those can sometimes be pockets of pus. This doesn't necessarily mean that it's infected. So you got to take the x-ray as part of a whole clinical picture together. Loosening, that can be diagnosed a few ways too. So you see it on x-ray too. What these are trying to show is that there's these kind of lines. So you can imagine if this metal stem is in the femur and this is loose, even microscopically, and it's windshield wipering back and forth, that's how you get a line like this. Sometimes you can see a line under the tray. And if there's any question, you can also get something called a bone scan, where they're radio labeled, usually it's a dye, and you can see if there's uptake under a tray. So that's kind of what that looks like. Instability means somebody who doesn't know anything about this should be able to look at that picture and say, something is not right. So that's kind of, can you see this by the way? Is my head, I'm not blocking anything? We're good? Okay, good. So this is a dislocated hip, and this is, people don't think of a knee being able to be dislocated, but they can be, and it's typically not good. Mechanical failure. So here you see, this is part of the metal. The knee replacement is broken. That's a broken stem. Things can be dissociated. These implants work very well, but they're not perfect, and they're subject to the same forces that everything else in life is. So steps of a revision. You need to get the old hip or knee out of the body. You need to make whatever adjustments you're going to do to make things right, and you need to put in the new components. But the simpler, basic way to think of it is get the old stuff out, fix the problem, put the new stuff in, and then there you go. So explanting the old components, this, if something's loose, sometimes you can just take it out with your hand. But sometimes you have to use specialized chisels to break up the implant between, or the interface between the bone and the cement. So that sometimes takes a lot of work because the goal is to be able to take it out with as little bone loss as possible so you keep the bone stock for any further procedures. Then this is showing kind of with the implants in, they've gotten them all out, then you look like something like this. You have a lot of space, and this is with the new components. And this middle step is where all the real work is, with trialing and making the adjustments. So this is kind of what some of the trials look like, where it looks kind of like a knee replacement, but you can see these slots in there. And these are made where if you need to resect additional bone, they kind of have specific measurements where you can do that. And this is for a tibia. I'm trying to think of a better, I think there's a picture here in a sec. But basically what all these are amount to is there's various tinkering that needs to be done, and that's why I spend the year doing all the bonus training. When you're trialing for a hip, what I'm trying to show here is usually there's a couple extra trays of different components, and on each of these stems, there are different neck lengths that you can put on in different angles, and this affects people's leg length and how much the hip out is to the side. Those can also affect the stability. And then with each ball that goes on, there's different lengths of that. So when you're in there, you put in the trials. You want to make sure that everything kind of feels right before you go in and put in the actual components. Then when you place the new components, it's not the same as going in the first time. You need to kind of get different types of fixation. So people talk about zonal fixation in the knee, where there's one right at the knee joint. Zone 2 is kind of where the top of the joint meets the shaft of the bone, and zone 3 is in the shaft of the bone. And typically you're using implants that will be able to get fixation, ideally in all 3 zones. In a hip, this is a different type of longer stems, and what this is called a tapered fluted stem. So this is essentially a very long, skinny cone that has these splines that as you prepare the bone and you sink it in, it will eventually stop and bite in, then the bone will grow to the metal. When you're doing a revision, you have a lot of different options. So you have different options on stem length. This green part here is trying to show things called augments, which are if you need specific extra metal in one area, there's ways of adding it. And then these are things called cones, which can fill kind of a central defect. Is all kind of making sense sort of so far? Yeah. Then on the hip side, you can there are ways of replacing the entire metal in the femur. It's not something that's common. In my training, I've done this once, but it's somebody who had essentially half of a femur and then broke around the other half, and kind of the only option left was to turn it entirely into a metal femur. That's called a total femur replacement. And then there's also within the socket side, which can be some of the most challenging things to redo. There's all different shapes of metal augments that you can put into the pelvis to kind of recreate a socket that's going to give you stability. Okay, so that was all the front part to kind of explain it. I think I don't remember, but just a bunch of different cases. These are kind of quick, so if you see something interesting or different here, it's a good time to chime in. So I started with something maybe not as crazy. This is a person who had a broken hip. When people break their hip, sometimes you fix it, sometimes you replace it. It's always good to have people keep their original parts if you can. So that's what these pins were trying to fix it. But ultimately, this kind of collapsed. You can see the pins backing out. And at that point, the best option for the person is to take this out, a fracture that didn't heal, and put it into a total hip replacement. So this one's not too crazy. You need to make sure you have the right driver for the screws. You get these out. And then after that, it's almost a normal primary hip. This is somebody who had a different type of hip fracture that you fix with, it's called a nail or a rod and screws. And then they went on to develop arthritis. So for this one, you first need to get this whole nail out, which is a little trickier than those screws. But then because of the geometry of the nail, which is a cylinder, you're not left with the same bone as you would be on a regular hip replacement. So you need to use a special type. This is one of those kind of conical stems to kind of bite in. And you can also see a break here, so you have to bypass that by a little bit. This one was not a revision, but this is a primary knee that kind of is acting like a revision because there's a huge amount of bone loss here, and this is an extreme amount of bow-leggedness. So when I'm looking at something like this, even for a primary knee, I know that I'm going to need kind of heavier duty components than something normal. I know that all the ligaments on the outside are going to be stretched out. Everything on the inside is going to be really contracted and tight, and I'm going to need to find some way to fill in this gap. Is that just a hand? Do you have a question or no? Oh, okay. So I ended up using a longer stem. Typically a knee would end here. Use a longer stem. And then the defect ended up being not as bad as I thought. So what I did was put in a couple screws to act as a rebar for cement to support under there. And then got him straightened out. This person had a knee replacement, then fell and broke right above it. And when you break right above a knee replacement, the question is there enough bone here to be able to fix, or is it the kind of thing that you need to take the whole thing out? So in this case, we were able to fix it. So these cables here are lining the bone back up, and then there's a rod that goes up through the leg and a big plate in the side. This is obviously a lot of metal to put in somebody's leg, but the benefit is this person can put their full weight on it immediately. Typically, people don't want to. It generally hurts a lot. But the goal of these surgeries are to mobilize people and get them up and walking so they don't lay around in bed and can heal up. This was another periprosthetic fracture. Except the problem here is this person already has a stem in their femur. So I can't put a rod in this leg. So again, line it up. The cables I used here are not made out of metal, so you can't really see them, but I used some cables to kind of clamp it down. And then this is a long plate on the outside to kind of protect that repair. This was another trickier one. So this person didn't have a hip or a knee in there, but looking at the space in their knee, they already have pretty bad arthritis. And just looking at the bone, it doesn't look like it has the greatest bone density. So in a bone that already isn't so healthy, fixing it is sometimes not the best option because you still would need to keep them not putting weight on it. So this is where I did one of those distal femur replacements. So I ended up making a cut right here, taking the whole broken piece out, and then putting in this kind of big hinged knee replacement. The tricky thing about this one is that if I had, now he had this whole stem in from before, and now a stem coming up here. So if this person were to fall again, this would break right in between them. So to try to mitigate that risk, you put on a plate on the side to span the defect and try and basically put the plate on before it ever breaks to prevent it from happening. This was one where there was not enough bone to fix. So again, there's another distal femur replacement. And this in here, this kind of trapezoid thing is one of those cones, which is another way of getting a biologic ingrowth. This is that kind of that zonal fixation. So there's cement under here, there's a cone in the middle, and then there's a long stem and cement kind of going in there. A lot of cement and a lot of metals kind of would be another way to name this talk. This person came to us, they had had a hip replacement, and at some point it dislocated. I got called, I think this was already 4 months out, and there was a wound that was just kind of draining pus. So now you're looking at this, you're dealing with infection and instability. So looking at this, since there's an infection, the bacteria can live on the metal very well. So you gotta get all the old metal out to have any hope of eradicating the infection. And then the other problem was with this wearing away, it wore away the whole roof of the socket. So thinking of how I'm going to get a new socket in there to stick with no roof, you got to find alternate ways of supporting it. So took everything out. This is all cement filling that defect of where the old head was kind of eroding the pelvis. And then I put in screws here again for that kind of rebar to kind of make a new roof and then cement in a piece of plastic. And then for the infection, they're getting antibiotics for a long time. This was another one kind of similar where this person had had this hip fracture that was fixed, didn't go on to heal, was also draining pus, and then has this screw rubbing around in their socket. So again, you kind of have to attack each problem individually. For the bone not healing, you can essentially cut the fracture out and put in a very long stem. For the infection, you take all the old metal out, and then because they went on to develop arthritis, cemented in a new socket. And this socket has a special metal ring where once the ball goes in, it is unable to be dislocated. So you have the benefit of the increased constraint and stability for a cost of maybe a little bit of decreased motion. But for a person who really needs to be able to heal this, you kind of have to pick and choose what sacrifices you make to get the best overall result. So this is a different type of primary stem. Is this overloading people with information? Are you guys still awake? Yes? Sort of? Okay. These types of stems, people were putting in a lot in the 90s, and this is the entire stem can get a porous ingrowth, so the bone will grow into it, which sounds like a great idea, except for what can happen is that the bone will react to this, and then people can get something called stress shielding around it, where because the metal is taking so much of the load, the bone resorbs a little bit, and people can get pain right at the tip of this stem. So this person came to me with pain right in the middle of their thigh. I worked her up for an infection. It was not infected. She wasn't dislocating it, so I know it wasn't unstable. I sent her for one of those bone scans that did not show that it was loose. And what we kind of ultimately settled on was that they were having pain right where the metal is really strong and the bone is weak. This specific point could feel those micro movements. So this is something called a strut graft. I'll actually go forward a slide and back, where essentially you take a piece of cadaver femur and you span the defect and find a way to, you roughen up the surface of the bone, and you can also put in, is this good? If people on the line have anything to say? Okay, good. And then you get this to heal to the bone, and it's basically an external to the bone way of kind of supporting it. And then I use those same cables to hold it on, but I use ones made out of suture so they don't show up on x-ray. It looks like it's just floating there, but it's strapped on tight. This is another infection one. Maybe I'll go forward first. This is what's called a primary knee, and this one was also infected. And when you are taking out a knee, there's different ways of doing what's called a spacer. Because if you take all this metal out, now it's just a big gap, and if you don't put anything there, you're leaving somebody with essentially a floppy leg. Some people would put a big rod across the whole knee and a big wad of cement, which kind of essentially gives somebody a peg leg. What I do in these cases is what's called a functional spacer. So these are real knee components. This one is a big piece of plastic. Add stems to them and put in high-dose antibiotic cement. And this is essentially a functional knee that we follow the patient to make sure that they clear the infection. And this has the benefit of, if a patient is able to clear the infection and they have a knee that functions well for them without pain, then you're kind of done with the surgery. But if they are unable to clear it or the knee is not functioning well, you can go in, take out this spacer, and do a formal revision knee. So it's a little bit a way of, to some degree, trying to play with house money, where the standard of care is what's called a two-stage revision. Take the stuff out, clear up the infection, put in a spacer, come back later, sometimes anywhere 2 months to 3 months away, take all that out and put in a revision knee. And with this, you have the benefit of, if everything works well, you've done one surgery. This was a person who their femur was well fixed, but the tibia you can kind of see lifting up here, windshield wipering here. So was able to leave the femur, but put in a new tibia. These ones are just kind of tricky because if you don't take the femur out, you don't have as much room to work. But it has the benefit of not removing a well-fixed component. So you try to, in all of these redo surgeries, the goal is to fix the problem without causing any undue trauma that you have to. This is another isolated tibia revision. So this person had a knee that, I drew this line on there. There's different ways of putting in a knee. Some people advocate for putting in the metal part at 90 degrees to the shaft of the bone. There are other reasons why you'd put it in a little angled. This is kind of a lot of angle. And you can also see under it, this didn't ingrow. So there's micro motion, and that's painful for people. So again, was able to leave the femur and put in a stemmed tibia. And sometimes this femur was not sized right, and you can kind of see a big gap over here. So this was loosening and causing patient pain. So I was able to leave the tibia and just change the femur, which I far prefer to do because that's just a lot easier for me. But so it goes. And then sometimes you have to replace both of them. So this person, this is a stemmed knee, but this is a primary knee, and they were having what's called flexion instability, meaning when the knee is bent to 90 degrees, you could kind of really move it around a lot front to back. So the way you have to change that is basically by filling up the space. So whenever you put in a knee in general, the goal is to put in what's called a balanced knee, meaning it can extend fully, it can flex very far back, and it's stable front to back, side to side. If you can have a mismatch, you don't want to make it where it's stable now with the knee bent, but then you can't fully straighten your knee. So there's different amounts of bone in different places where you would take the bone away in order to do that. So with this person, maybe it's hard to see, but looking from, this is the side view of the knee. So here's the front and here's the back. This, we kind of increased what's called posterior femoral offset, so that when the knee is bent, you can almost imagine if this person turned their knee, it would be a little more kind of full front to back to kind of tighten everything up. This person had another what's called global instability, where it's loose in flexion and loose in extension. And the other thing is, looking at the side view, this tibial component should be sloped backwards, and this one had what was called a reverse slope. So that just doesn't really work, and people don't like their knee. So took it out, and this is, again, stemmed components in both of them. This one also is a little interesting, because when you're trying to get these revision stems to fit in there, you can cement them into the bone, or you can get a scratch fit. They each have their own kind of benefits and drawbacks. This is cemented up top because the trowels are sitting well, but because of the shape of this person's tibia, I had to use a press fit stem where you can put these. You see how there's this kind of angle here? Has a built-in offset, and there's almost like a clock face where you can kind of dial that in whichever direction, so that the stem is getting fixation in the bone, but then the tray is sitting right where you want on the top. So I put this one in here basically to say, when we go in there, there's a lot of different tools you have to kind of make things right. And this is the same thing. This is kind of an offset stem anteriorly, but cemented down here. This has, you can kind of see loosening on the back of this. That's what we did here. And these designs are kind of, they call it a clothespin design, so that as you hammer it in, the clothespin can sometimes kind of cinch down a little bit, and it makes it a more smooth transition between the bone and the metal, and not just a stark kind of difference. This was a very bad one, where the person had worn out their plastic and left it alone for a long time, and it is rubs on the metal, and all of this stuff you see are metal particles in the knee. When I opened this one up, it was black just from the metal particles. The other thing is the body reacts to those particles by chewing away bone. So when I took this component off, all of the bone behind it was literally like a black goo. So you can't support metal in there. So in this case, had to make the cut here and then do another one of these kind of distal femur replacements. And that's kind of the side view, and that's what that distal femur replacement looks like outside of the bone. Big stems up and down, and these components are truly linked as a hinge. This is another kind of case of that particle disease. The metal can make particles that the bone eats away, and the plastic can also make those particles. So looking at this, you can kind of see two almost little blebs. That's called osteolysis, which is what it's called when the bone reacts to the plastic. This is a CAT scan I got kind of showing that better, because I know that when I go in there to take out this socket and put in a new one, you could be left with a giant cavity, which if you don't have the proper tools to fill that cavity, you're not going to be able to put a new socket in. So this is what's called an acetabular augment, which is basically a big piece of porous metal. And I was able to leave the femur, put in a new socket, fill this all in with metal and bone graft. And then when you're putting in a new socket, you typically are also going to put in some screws to help get initial fixation until the bone grows to the metal. That's kind of the side view, just showing the augment again. This is kind of what those augments look like. Regular cup, and then they're usually shaped almost like a lemon wedge or an orange wedge, and it's a way of turning an oblong defect into a spherical defect that could then take the cup. And they also make them for this. This is if somebody didn't have any more like of the wall of the socket. So this can kind of supplement a wall, and then you would kind of use cement to unitize the augment to the cup. This is a person who had a hip replacement and then fell a week later and broke their femur here. So this was loose and fractured. So we were able to leave the socket, but I use these cables to close down the fracture, and you're not going to get fixation up here anymore. So now you need to get fixation in the shaft, which is why you use one of these long revision stems. This one was revised for an infection. So again, everything came out, new stem in. But it wasn't unstable or anything like that, so we didn't need to do that. This person has obviously had several surgeries, as you can see on this side, but this was a socket that was placed in the early 1980s and was all plastic. And just based on the available components at the time, this is a really tiny ball. The bigger the ball in the hip, the harder it is to dislocate. So this person was wearing away the plastic over years and years and kept dislocating. So I was able to leave everything here, take this out, put in a socket, and then put in a much bigger ball that is able to keep the hip where it needs to be. On the other side, which I did not touch, this is called a proximal femur replacement, and this is essentially a step short of doing a total femur if there's either no bone or everything is worn away. Sometimes this is a thing that people do orthopedic oncology. They deal with a tumor prosthesis. If you have to take away the whole top half of a bone, it'll look something like that. This was a dislocating hip, and it was too short, so had to take this out and put in a new one of these stems. That was not that exciting, I guess. This is probably the most complicated surgery I've done. I've been at this hospital for about 3 years now. This is probably the most complicated one I've had to deal with. So this is, again, a primary hip. There's no hip replacement already in there. This is what the ball should like. Over years away, this kind of worn into almost a little nub, but that is not the problem. The problem to me is, see how the size of this socket, this is probably twice as big as that. So this is where you need to use tools to fill in the void. So put the socket here. This is an acetabular augment. We finished up with the surgery. I was feeling really good about myself. I thought it looked so good. And then a few weeks later, the patient fell, broke the augment, cup was going in there. So I had to take all that out, put in a giant cup, this is something called a cage that helps stop the cup from migrating into the pelvis. And then into the cage, you cement in one of these plastic liners, which kind of looks like this. So big cup, the cage is almost a plate. I was kind of making sense. And then into this thing, you would cement in the plastic. So there it is again. And then there's screws going through the cup into the pelvis, and also try and get some into all the different parts of the pelvis. So you have kind of almost a triangular points of fixation so that the cup is not going to move. That's what those kind of cages look like. This wasn't done here. This is when I was in fellowship. This is the worst surgery I've ever been a part of. This person came to us, had their hip replacement done, I think 2 months prior, and fell, broke the socket into the pelvis, and exploded their femur. So there's a lot of problems here. You need to get all this stuff out, which actually shouldn't be too bad, except for the major blood vessels going to your leg are hanging out right here. Those are typically things you don't want to get into. And there's a bunch of pointy screws sticking out of this. So the best way to get these out is carefully. And we did that, put in a cup cage, and then there's not enough femur left to really put a new replacement on. So this person there's the cup, there's the cage. This kind of has all the things, there's a good summary of the whole everything. Cup, cage, cemented one of those constrained liners in, and then that's a proximal femur replacement. And these people, you would have them kind of protect their weight bearing usually for 6 weeks, and then they're up moving around. And that's all I have. Thanks for coming. I appreciate it. Yeah. Yeah.
That's fantastic. Your presentation is fantastic.
Thank you.
They still use nothing but the factory plate for the cement?
Yes. So even a primary hip and knee, some people will cement knees right away. Some people will press fit them in with kind of a scratch fit. But it's a polymethyl methacrylate cement. Different companies have them. There's different viscosities. Some of them have added antibiotics. Some of them don't. When I'm doing one of these spacers, I will use the antibiotic cement. I will add additional antibiotics to it, which has the benefit of delivering more antibiotics at a site of infection, but there's a trade-off. The more non-cement powder you're adding to this mix, you are theoretically weakening the bonds of the cement. And then I also will add blue dye into the cement when I'm putting it in there, because if I ever go back, then it's very easy to see what's cement and what's bone. But typically people are using PMMA cement. And then on just with primary hip and knee, most of the time in, I would say, the world, people are cementing the knee, the components into the bone. And the cement is more of a grout than a glue, if that kind of makes sense. When you press fit it on, no cement, but the metal itself has a porous nature that is similar enough to bone that if you put it on snug enough, within 6 to 8 weeks, the bone will grow into the metal. I typically prefer to do that because I think any biologic fixation is, I think, inherently better than a non-biologic. Because if there is any trauma to it, if you crack the cement, it's toast. The cement will be the best it's ever going to be when you put it in. It can only get worse or be the same. But if you have a biologic fixation, it can tolerate more damage and potentially heal it up. But I always have both available because you don't ever want to be in a spot where you need something and don't have it. Yes, Bob.
Is there a best or recommended diet or medication or vitamin to help after you've had one or more of these procedures to help it heal better, to help it heal faster?
Not necessarily to help it heal any faster. I mean, healing in general, you would want a high protein diet. Typically, I think what maybe you're thinking of is if somebody breaks a bone, I have a little sheet I give people on foods or supplements that have a lot of calcium and vitamin D. But for the bone to be able to adhere to the metal, well, one, if you cement it, you don't need to worry about it. It's in there good, you would hope. And then for the bone to grow into the press fit metal, there's 3 factors that it takes into account. You need to have less than 50 micrometers of motion, so you need to really scratch fit it in there. The metal itself needs to be at least 50% porous, and the pores itself need to be, I think, on an average of 50 microns. And that's similar to bone. What people used to use in a lot of these companies is elemental tantalum because that is very similar to bone. And now they will do 3D printed titaniums so they can kind of make it exactly how you want it to be. Yeah. I don't know if that really answered it, but.
It sounds like really just a good diet and
Yeah.
new vitamin or.
Yeah. Anything calcium and vitamin D, your bones will like. Yeah. Chocolate milk, that's good. Write that one down. Yeah. Yes.
Based on your presentation, I can't imagine, I haven't seen all the scenarios, that there would be any contraindications, more specifically absolute contraindications to a revision. Whether it's hip or
An absolute contraindication. Sometimes if somebody has failed multiple 2-stage revision procedures for an infection, each time you do it, the chance of eradicating the infection goes down. I don't know that I can see. I don't know that anyone's asked me that. If there was no bone at all, I think that would be one. What more often I think I encounter is there's the book answer and then there's real life. And sometimes if somebody you kind of see is the cure worse than the disease? And I think sometimes, depending on what the problem is, this is such a case-by-case kind of thing, where let's say somebody was extremely unhealthy, they would not be able to tolerate the surgery from an anesthesia or recovery perspective, you would maybe say, and again, depends on what the problem is. If somebody's like instability of a hip, you can put them in a brace or different types of things, and some of that is also therapy, kind of coaching people on what not to do. Fracture-wise, there's ways to fix almost everything. There's a lot of ways to handle instability. There's a lot of ways to handle bone loss. I don't know. I am very lucky that I'm doing this now and not in 1965, because the explosion of all the different companies that make these implants, the stuff I have now to use is so good that if I have planned it out well and prepared, I can have something to fix almost any problem. But part of that is that there's a lot of planning that goes into these on the front side. And I have to go into any revision case with a plan A, B, and C. And even then, stuff comes up that you maybe didn't expect or weren't prepared for. And then I have to make sure that, there's a lot of people that go into, I'm in there doing the surgery, but my office staff is getting it ready. The OR team is getting all these things. There's sometimes on a case, I'll have reps from 4 different companies to have the different things I need. So I rely on a lot of people, but the stuff is pretty good in general. So I'm lucky in that regard. Yeah.
Doctor, I hope I'm wording this question correctly, but anything innovative to deal with scar tissue?
I don't know the answer to that one as much. You're saying like deep scar tissue or like the scar on like your skin at the end?
Well, just the fact that a person doesn't have the range of motion that they should have. I'll just say in my case,
Yeah.
I have no pain. I had a total and a revision of that. But my knee feels like there's 500 rubber bands wrapped around it. And it just doesn't have the range of motion to the correct degree.
Yeah, stiff. So anytime you go in and do a revision of a hip or a knee, there's always an increased risk of stiffness and an increased risk of infection. And there's not, in the OR, I imagine whoever did your revision knee, in the OR, you want to be able to get the knee to be all the way straight, bend back to 120 degrees, and then afterwards, it's kind of how your body's going to react to it, and everybody's body reacts a little differently. And I'm sure, you do a bunch of physical therapy. I don't know if I have a great answer to that one. That, sometimes I am also a little bit at the mercy of the people on the medicine side of things to figure out if there's other pathways or medical ways of kind of having your body not lay as much scar tissue down. That I don't know the answer to. I know a lot about getting metal into or taking metal out of the body, but all the soft tissues around it, I think, okay telling you that that's not as much my wheelhouse. Yeah. Yeah, I don't know if that really answered things, but.
We come to you for surgery, and
Sure.
then we have after visit.
Yes.
After that, from there on, where do we go? We go to our primary care, we take care of us?
So, like after the surgery? So typically after surgery, I see people 2 weeks for a wound check, 6 weeks, 3 months, 1 year, and then I tell people I want to see them every year after that to get a serial X-ray until I die or they die.
So the primary care has got nothing to do with
Let me put it this way. If I do a surgery on you or anybody, I am signing up to see them indefinitely. And I think some of those annual follow-ups are to kind of, you're monitoring the plastic, you're monitoring other things. If I, like this guy, let me go back to him. So this person, if you theoretically, and again, you can't know, the past is in the past, but if I had started to see early wear of this plastic, which you would see as a thinning, you could take this person to surgery, pop the old plastic out, pop the new plastic in before it becomes a big problem. So that's kind of why I like seeing people. At the 1 year visit, I give people a choice. I say, we can either do this annually, or, and some people don't want to come see me once a year. It doesn't feel like that much to me, but maybe it's just to them. Say, or you can do every 2 to 3 years. The only problem is our clinic can only schedule a year in advance. So I say, if you want to do every 2 or 3, I'm fine with that. You just got to remember to call me. But if I've done a surgery on somebody, we're kind of in it for the long haul. All right, these are good questions. Anything else? Josie? We have a PA student with us for the month, our first student. So I forced her to come to this. I don't know. Well, that's all I have. Anything from the internet world?